Hello to you all, and I would like to thank the organizing committee as well for inviting me and giving me the opportunity. Child and adolescent depression are seen very frequently. It is 1 or 2% for children, and it is higher for adolescents, between 3 and 8%. And in some trials, we see that lifetime prevalence by the end of adolescence is 20%. I will be a bit fast. Please bear with me. This is a prevalence trial in 2011, and this is a table which was taken from that study. And the highest rate in terms of lifetime prevalence at the end of adolescence is anxiety disorders, then behavioral disorders, and in the third rank we see depression and mood disorders. Mood disorders are in the rate of 15% according to this trial. The interesting point is that anxiety disorders are seen very frequently. However, they do not, in terms of significant disorders and affecting the life, it is 8%. 32% is general anxiety disorders, but which affect the life is only 8%. Again, we see depression. It is close to anxiety disorder. Compared to many other diseases, it has very significant effects on the life of the person. In children and adolescents with depression, we see very important problems in social relationships, significant morbidity and family burden, educational and occupational underachievement, obesity, alcohol, tobacco, and substance use, risky sexual behavior, and some other problems can be seen with this children and adolescents. And in the forthcoming years, depression may cause the behavioral disorder. And in 50% of child and adolescents with depression, we see suicidal event or suicidal thinking. If it is left untreated, depression can affect the youth's development of social, emotional, and cognitive skills. It's a bit different from the adults because the young people are still in their development phases. In the treatment resistant, it also may cause treatment-resistant depression. If there is a depression in the adolescents, in the next 5 years, this depression will relapse in a probability of 70%. Adolescent who experiences depression is 4 times more likely to develop a depressive episode in adulthood compared to other adolescents without having this risk. In terms of treatment, psychotherapy, pharmacotherapy, and combined therapy is suggested and recommended. In terms of psychotherapy, CBT and interpersonal therapy are the most researched and recommended methods. For pharmacotherapy, we see TCAs, SSRIs are studied, and for pharmacotherapy, I'm not going to go into the details. It is already known, but in terms of TCA, for the treatment of depression in children and adolescents, there is no proof and evidence. Fluoxetine is one of the most frequently used drugs. Escitalopram is proven to be effective in adults. FDA is giving its approval for the age group above 12. Citalopram there is not enough evidence about that. Sertraline, there is not enough evidence likewise. Paroxetine is not suggested in terms of its efficacy and in terms of its side effect parameters. It's a bit risky, therefore it's not very much recommended and preferred. Here, I would like to talk about the comparative studies, TATS, ADAPT, and TORDIA trials are very much famous. This is TATS. It's a randomized controlled between the ages of 12 and 17. 439 participants are present. All of them have a major depressive disorder according to the criterion DSM-4. One group receives only fluoxetine, the other CBT, the other fluoxetine plus CBT, in other words, the combined treatment, and third group receives placebo. And the Children's Depression Rating Scales revised is used. Clinical Global Impressions improvements are used for evaluation purposes. Reynolds Adolescent Depression Scale is also used. The Suicidal Ideation Questionnaire, junior high school version, is used for evaluation purposes. These are the results. The most effective group is the combined treatment with 71%, then fluoxetine. In the third rank, we see CBT CBT, and then we see placebo. These rates are based on the response rates, clinical global observation scale. These are the rates based on the response rates at the end of 12 weeks. These are the percentiles in terms of statistical significance. Placebo and CBT are not very much different from one another. These are the scale, depression scale rating. In order to reduce the severity of depression, combined treatment is better than fluoxetine, and it is better than CBT. However, the difference between placebo and this one is for only one type of treatment it is significant. For the others, it is not very significant. The most effective one is the combined treatment. Let's look at the acute time to response. CGI 1 or 2 is taken as basis. So acute response is 1 or 2 on CGI scale, and so the time that has elapsed since the beginning is called acute response time. Time to response, first time the response was obtained, and stable time to response is at the end of the first time 2 consecutive responses were obtained. What we see on the basis of the results is that this is done in 2 ways. Pharmacotherapists and psychotherapists are evaluating this. According to the evaluation of pharmacotherapists, combined treatment is equal to fluoxetine. It is better than placebo. However, there are some things in the parentheses. These are the figures, are the number of weeks that is necessary, and we get the response after 5 weeks for the combined, and it is 6 weeks for fluoxetine and for 11 weeks for placebo. According to psychotherapist evaluation, it is 6 weeks for combined treatment, and for CBT it is 8 weeks. You can see the difference here in the graph. The combination therapy is superior, but it is followed by fluoxetine treatment. In terms of stable first time to response, the combined treatment is of course superior. It is better than the other types. For placebo, only 38% is the result after 12 weeks, and for according to psychotherapists' evaluation, the combined treatment is better. In terms of a stable response, combination therapy is superior. Let's look at the long-term results. 12-week, 18-week, and 36-week. When we come to the 18th week, the combination treatment is superior, but fluoxetine treatment and CBT treatment are almost equal. At the 36th week, we can see no statistical difference in between, but all of the methods provide a significant response at the end of the 36th week. Here, after the 30th week, we see that the difference is diminishing and is disappearing. And this is 1 year naturalistic follow-up. And in each group, the differences are diminishing, and there is no significant difference at the very end. In terms of suicidal thinking, for 12-week results, combined treatment is better than the other ones in order to decrease this thinking. But at the 36th week, combined treatment is equal to CBT, but fluoxetine is less than these 2 groups. But do not misunderstand me. I'm not saying that antidepressants are increasing the suicidal thinking. On the opposite, the antidepressants are decreasing the suicidal thinking, but it is less than the combined treatment and CBT. So this is the graph for the treatment modalities. At the end of the first year, it does not change a lot. Likewise, combined treatment and CBT are more effective, and fluoxetine alone is decreasing this type of thinking less when compared to the others. In summary, with regard to TATS, I can say that combination therapy is the most effective in the short term. When we use drugs, the drug facilitates the response, and in the long term, there is no significant difference, and CBT is protective for suicidal events. This is the TORDIA trial. And it is for the depression cases that are resistant against treatment. It continued. It included the adolescents which had not responded for 2 months to an SSRI, and one group receives SSRI plus CBT. One group receives another SSRI, and one group receives venlafaxine, and the other groups gets venlafaxine plus CBT. So at the very end, when we add a CBT for both groups, in other words, changing SSRI and venlafaxine is given to one group. So for both groups, we increase response to treatment. So in other words, in cases of depression where there is resistance to treatment, CBT is also effective. This is the ADAPT trial carried out in the UK. So this is moderate, severe, major depression children and adolescents. For a short period of time, an intervention is made, and if they do not respond to that, they are included in the trial, and for 28 weeks, one group receives SSRI and routine care, and the other group SSRI plus routine care plus CBT. Very interesting results are present in this trial. It's a bit opposite to the TACS results. According to CGI 1 or 2, there is a 61% improvement for the first group and 53% for the second group. In other words, in the group where there is SSRI only, we get a more effective result, and the difference between them is not statistically significant. There is no evidence with regard to prevention of suicidal thinking. And in addition to this, adding CBT is not very cost effective. This is a graphic representation of the difference in between. Kennard has a study on that. This is for depressive youngs responded to fluoxetine treatment, and in one group they continue with the fluoxetine, and in the other group fluoxetine plus CBT is given. In the very end, relapses is seen less frequently when CBT is added. In other words, adding CBT is preventing relapses as well. The last two trials, one of them is carried out by Clark, and in one of them one SSRI is given, and in the other group SSRI plus brief CBT is given. And there is a little difference which is not very significant in terms of improving depression, and this is the last study. It is by Melvin, and sertraline is studied here. There are three groups: sertraline CBT and sertraline plus CBT. The CBT group is better than sertraline alone, and this combination treatment is not different. Combination treatment is not different from CRT or CBT, and it may be related to depression severity or low doses of sertraline. We did not have very major depression cases or significant depression cases. Therefore, they say that sertraline may not have an effect, or they say that we have low doses of sertraline in this trial, therefore we may not have received very good results in that. This is the graphic representation, and CBT is the most effective one. In conclusion, I would like to say that psychotherapy can be used if there is mild to moderate depression. Psychotherapy should be used as a first-line treatment. If psychotherapy psychotherapy can prevent suicidal events and suicidal thinking, and it may improve long-term outcomes. That's what the studies say. And pharmacotherapy, if there is moderate to severe depression, first of all, pharmacotherapy should be added. And pharmacotherapy can be used if we need accelerated response, if it really has negative impacts on the life of the child or the adolescent. Pharmacotherapy or medication may accelerate the response to treatment. That's all I would like to say, and I would like to thank you for your patience.